Welcome back to another episode of Kate and Isaiah Living Large. I'm Isaiah.
And I'm Kate. And on today's episode, we have a very special guest that we've been talking about on the podcast for a long time. To kick off our new year, we've got Dr. Mike Pelkey, also known as my brother-in-law, because I'm sure that's what he goes around the hospital. I'm Caitlin Dean's brother-in-law. He's an endocrinologist, and he's going to tell us what an endocrinologist is right now.
So an endocrinologist is a specialist who deals with hormones for the main part. And in our purview, certainly weight comes up as often a topic. So we're going to have a conversation around weight and obesity today. But I do have to say that nothing I say, this will all be generalities, can be taken as individual advice to any one particular person. And if someone ever does want to start an exercise program, all of our guidelines would suggest see your primary care physician first if you're middle age or older, because you don't want to get injury while you're trying to get healthy.
That's great advice. What is middle age anyway? Am I middle aged now?
Yes, you are.
Okay.
Where does middle age hit? Is it 40 or is it?
I think 40 is a pretty good number. Sadly, I like to keep pushing it forward, and I'm thinking now maybe it's 50, but eventually you got to get used to the fact
that we're middle aged.
Middle aged.
Yeah.
I got like a few more years then.
Yeah.
just shove that in there a little bit.
So essentially, what we're all very curious about as we kick off the new year, and so many people are going to start weight loss programs and things like that. Why is it that some people are obese, which is the medical term, and some people aren't, despite lifestyle choices, etc.? Because, you know, there's lots of people who walk around the world doing very unhealthy things who are probably rather unhealthy, but are not fat. Like, why is it some people are and some people aren't?
Oh, there's a lot of factors that play a role with that, and I'm not sure we've got them all figured out at this stage. Excuse me. Genetics certainly plays a role. There's no question that we often see obesity, which again, I am going to use that term because it is the medical term, and it's kind of sad that society has made it a swear word or something offensive. But it is how we discuss overweight. So there's activity levels, there's genetics on how your metabolism is set up, combination with dietary intake. Oftentimes medications that people may be on may play a role with weight changes, other conditions that they have. So there are some conditions that will lead to weight gain regardless of what you do. The thing, even other interplays, they even wonder if the bacteria in your gut plays a role. They've done little studies where they took chubby mice and thin mice and changed their bowel contents, and the weight changed. So we don't have nearly the full grasp on why somebody can eat a pizza and not gain a pound, and someone can look at a pizza and does gain. But we do know overall the best way to look at it is what we can control, energy in and energy out. So what you eat and what you do, but it is not that simple in most cases.
And do you find that the research in that area has it become drastically different from when you first got into it? I don't know how long have you been in the world of, I can't pronounce the name, endocrinology?
Yeah, that's correct. Hormones.
Yeah. Do you find that the world of studying that has changed since you first started into it?
Oh, of course. Yeah. I mean, 15 years now that I've been in practice, or will be this coming summer. And if you add my training in, means 20 years of it altogether. So there's everything has changed. There would be very few things that have not taken different tacks. And probably one of the biggest ones, I think, is there's certainly more of a trend to looking at obesity as a disease process. I think in the past, and still with a lot of physicians, I suspect it's looked at as a lifestyle choice, a willpower thing. And although there are certainly overlays, nothing in medicine is ever 100%. There are things that play a role that are outside of our control. So the study now is moving towards how can we monitor and manage that, and what's effective in that treatment, because they've done a lot of research on diet and exercise, and now we're moving on to, hey, what can we do with genetics? What can we do with other physiology that might play a role with this? And it'll keep changing. There's no question.
Okay.
And how does that change over time when you look at how you've dealt with patients 20 years ago when you were starting out as a resident and as you were being trained versus how you deal with a patient now who's presenting as obese, and likely if they're presenting to you, they probably have some other issues such as diabetes or something like that. How has your personal practice changed on that front?
I'm not sure that my personal practice in terms of how I would approach somebody has changed a lot, other than perhaps we know more on what will or won't work, or we have more options that we can discuss, right? You know, back when I first started, for example, bariatric surgery were the lap bands. And they just don't do those anymore, right? So, I mean, obviously, 20 years ago, bariatric surgery was a lot of complications. Nowadays, it is certainly more streamlined, and so our options are certainly different now than they were 20 years ago in conversation. We always start this conversation the same way because obesity itself hasn't changed. Our understanding perhaps has, but the condition itself has really been more prevalent in the last maybe 70 to 100 years. So it in itself has the reason why somebody sitting in front of me isn't particularly different. And I always find that the first bunch of the conversation is to chat about, okay, why are you here? Because if weight loss was easy, none of us would have weight problems, right? Like, I carry a belly, there's no question. And I say, how? Because I should know better, right? I get told that a lot. But it's not straightforward. Nobody was born into this world thinking, I can't wait to get fat. Right? And it's just, so if it was easy, then there wouldn't be an issue. And so people come in frustrated. And most of the first time, before we ever get to talking about treatments and how things work, is to just talk about the condition itself.
And what risks? So maybe we should start by defining what obesity is, because I don't think obesity is somebody who has 10 pounds to lose, but maybe I'm wrong.
Yeah, so medically defining overweight is a BMI. Everybody heard of a body mass index? What BMI means? Okay, so
we've talked about it a few times on.
Yeah. Hey, you can always argue. So that's one other thing I'll say. Where this has become such a touchy topic and a socialized topic, perhaps. There be 75 million things online that you could go read, and they're not all going to agree. And so I could say, hey, we talk about BMI. And some people say, well, that's probably not the best measure. No, you can talk waist circumference. But when we're talking about defining it, overweight would be a BMI of over 25, and obesity would be above 30. And then you can grade obesity to stage 1, 2, 3, depending on your BMI from there, or you can grade it with complications, right? So if you have a BMI of above 40, we don't like the term, but it is used as morbidly obese. And so, hey, now you have indication for surgery. But if you've got a BMI of 35 and you've got diabetes and hypertension and high cholesterol, that's complicated. We would treat that somewhat similar. So we grade it by, because we like to define, right? We, maybe you look at somebody with a BMI of 28 and say, oh crap, that's not bad. Okay, fair enough. But this is how we define, and our interventions then go with complications on top of it.
Right. Like you say, if somebody has a BMI of 28, but they're also diabetic, well, then it's graded differently. Is that what you're saying?
Well, we would, that. So if you had a BMI of 28 and everything was fine and dandy, we might start with, talking about diet and exercise. But if you had diabetes and a BMI of 28, then the conversation might be more about the diabetes. What medications could we use that won't add to your weight, might actually help? So it may change how we medically manage somebody's blood sugars in that scenario.
That makes sense. So you're using BMI not as the sole proprietor, but as a dot in the aspects.
It's a good starting off point.
Gotcha.
It's a good jumping off point. Yeah. And then everything's different from there.
But you don't live and die by BMI.
Well, no, I mean, you look at an NFL football player who's 250 pounds and 3% body fat, and then the offensive lineman who might be 250 pounds and 60% body fat. I don't know. They're very different. So, I mean, your BMI might be the same, but there's certainly a difference there,
Right.
the composition. So everything, and that's the trick with everything in medicine, is you get your starting point, but then you tweak. And if someone comes in as a bodybuilder at the gym and rock solid muscle, then that's, then that BMI doesn't help.
Yeah.
Type idea.
That makes sense. That makes sense.
But for the average Joe, it's a good indicator.
That makes sense. And what risks does being obese present to people?
In a short word, pretty much everything. That's the problem. So you can look at, there are things that it increases the rates of. So it increases rates of diabetes and blood pressure and cholesterol. It increases rates of bone and joint things. So arthritis is common. Blood flows back to your heart against gravity. And so if you've got a belly pushing down, then leg swelling and edema, and then subsequently ulcers and things like that can come from it. But it interferes with, there's higher rates of cancer I'd have to dig out some books to tell you exactly which ones. I don't have it all up in there, that's for sure. But there are higher rates of cancer, certainly infertility from both the men and the women's side. If an obese lady gets pregnant, it'd be considered a higher risk pregnancy, needs more monitoring. So even things like reproduction are affected by it. Certainly the mental health aspects, which I don't deal with quite a bit, more there, how much of it's related to just the fact of body image in today's society where it's a touchy topic, versus is there actually an increase from a baseline of mental health disorders that depression that goes with it. So no, obesity has an impact. And there is something online that's starting to worry us a little bit. And you'll find that there's a trend online in some places where people say, oh, weight doesn't matter, it doesn't have an impact, but it does. And they talk about, metabolically healthy obese, so somebody who's carrying too much weight, but it goes and walks every day and doesn't have diabetes and cholesterol. Does it really make a difference? And there actually have been some population studies that even if you are metabolically healthy, regular exercise, in pretty good shape, but are carrying body weight compared to somebody of a normal weight, same age, your death rates and complication rates are still higher. So unfortunately, we are not designed to carry a lot of extra weight. But we are also not designed to easily lose the weight. And I think that's one of the biggest things that I start with people. Why is it so hard to lose weight? The way I look at it is, ultimately, think about it, weight loss is fatal.
Yeah.
Our body just doesn't know when. So you start to lose weight and you feel better and everything's great, and you cross 5% of body weight and everything's great, and you get down to 10% of body weight loss, and it's kind of like, wait a second, it's like your accountant saying, dude, you're spending your savings. your retirement package is dwindling here. So your body kind of kicks in and does a similar thing and starts to say, okay, wait a second. This can't, if you lose a pound, if any of us here lost a pound a week and without stop, then we don't get old age. None of us, right? Imagine someone 120 pounds losing a pound a week. They're not healthy when it comes summertime next year.
Right.
So we have a lot of things in play that once you've started losing weight, to prevent it. The problem is our bodies just can't tell. Like, we weren't designed to carry this to start with. So when we start to lose it, our body starts to say, okay, no, we can't lose weight. We just it can't tell when it's a good, safe place to be. I could get more technical. I'm trying not to be confusing, but.
No, it's great. It's great information. So I guess we've kind of touched on genetics a little bit on it also affecting us. I guess it works in both ways, right? For skinny people that need to gain weight, I assume genetics also plays a role in that as well.
Well, genetics plays, again, and I couldn't tell you what percentage, right? So you can certainly have the genetics to gain weight, but not, right? Or you could have, you could have a genetics, and everybody out there has got that friend who's 130 pounds and can eat a half a pizza and you kind of want to biff them out a window type of idea. but they eventually it will catch up, so to speak. So genetics is a component. Lifestyle is a component. There's a lot of different components, which is what makes it so challenging. So yeah, there are going to be people that don't struggle with weight and crap. Frankly, I can't speak medically to this, but I tell the residents and students, because they're all 25 years of age, said, you know what, you hit 5, it slows down. You hit 30. You just don't get away with what you get away with in the past. Right. And it kind of can catch up to you. So there's a lot of different, more so than just the genetics for sure. Yeah.
And in terms of, you talk about in the medical community, I will go back to what you're saying about the movement of like, well, it doesn't matter. I mean, and I think that is important from a social perspective. Like, yeah, you should be able to buy clothes and things like that fit you and move around the world as a large person. And I think that is pretty an acceptance of the fact that there are people living like that. Otherwise, it's somebody who's being prejudiced against in some way because of how they are. Having said that, medically, that's a completely different matter. That's what you're saying, right?
Yeah, well, I mean, certainly, what's the expression? Love the sinner, not the sin, so to speak.
Right.
I'm not calling obesity a sin by any stretch of the imagination, but the thing is no, we shouldn't prejudice against anybody who, carries too much weight, or we prejudice against somebody with anorexia who struggles with it. They are sick and they need help, and it's. And so, yes, absolutely. Somebody who's large should have no limitations, right? in my mind, there should be no discrimination. Should be able to do, whatever job you can do. Now, if you're, 500 pounds and decide you want to go out and cut lumber in the woods all day, you might want to rethink that. So I mean, there are some things that are just
you can't do.
You just can't do. But that's not discrimination. That's just physical. So, but the thing is that okay, that's great. We shouldn't discriminate against smokers. Right. But that doesn't mean smoking is healthy. And what can we do to get to a more healthy state? So in the medical side, no, we don't discriminate. We don't sit down. Someone comes in the office and I say, how did you get here? Why'd you do this? No, you say, okay, here's where we are. And it's not an easy fix, but we need to work forward with it. And let's work our way through. You have complications that we need to deal with. Have we worked up any medical causes that may have led to this? Unfortunately, there's not a lot. The internet will tell you there's tons, but unfortunately, it's rarely the case. All right. So what things can we do differently from a behavioral aspect, from a diet and exercise aspect, from a medical aspect? So we approach it as a condition, not a state of being, but a condition that's having an impact on health. And how can we help?
Because
does that make sense?
Yeah, it totally does. Because there is a fear, and I mean I've experienced this myself, where you don't want to go to the doctor about weight related issues because the last thing you want them to tell you is thing that you already know in your head,
right?
And make you feel bad about it, and so the fact that is a pendulum shift. Like even when I was a teenager and going to the doctor, and I was a lot less heavy than I am today, and they're like, well, you need to diet and exercise more, and there has been a bit of a paradigm shift in the last 20 years.
Yeah, I mean, you're still going to find doctors and nurses and healthcare professionals who are going to say, oh, you're overweight and this is why you're here. And why are we, you're going to have, even this day and age, you're going to run into health professionals who probably don't fully understand the difficulty that goes with, you say to them, you really believe that I would keep this on if it was that easy? But most physicians, and I can tell you the training the residents and students are going through is very different training in terms of a viewpoint on it. And in terms of, okay, I think you're getting that. I know I'm kind of rambling now. Sorry about that.
That's what we want.
But I think you're getting that for a lot of things. Like in the first 10 years of my career, the first maybe 6 or 7 years, like transgender was, people hid it. They kind of came in not because it just wasn't, it was, I've seen people get beat up from it. Now, I'm not saying that doesn't happen now, but certainly the pendulum shift in society certainly improved from that. And the same thing with weight. So a lot of these touchy hot topics, I think society is becoming more accepting of the fact that they exist and that it's not a state that people have chosen. And now how do we help if there's health related issues? And I think doctors are getting, I'd like to think they're getting better at that. You know, not saying, okay, this is all your fault, but okay, what aspects can you change? What aspects can I help you with? And why is it going to be a battle? And focus on it as a condition.
And
So, if I'm saying that correctly.
yeah, that totally makes sense. And in that, for what does success look like in, you know, short, medium term, long term goals?
Well, and that's where the internet starts to color it. That's where society starts to play. So one of the hardest things is when somebody comes in and trying to get set what are reasonable goals. So lifestyle change, diet and exercise in general. Now, again, this is the thing, because you'll have somebody out there saying, well, I did this diet and I lost 97 pounds and I've kept it off. And there are most certainly people on the outliers, and no matter what they do doesn't work and everything they do works. But for 95+% of people, you know, I can't even remember where I started. Sorry about that.
That's okay. What does success look like? Is the question.
So for 95% of people, you start with diet and exercise. You can expect perhaps 5 to 10% body weight loss with good diligent work before it starts to plateau. Right, and it's that plateau where people start to get frustrated. It's that plateau where your body is now trying to put the savings back in the bank, right? You can't keep losing weight. And so a lot of times, in 97% of people, there's a rebound back once you kind of got that 5 to 10% down. They rebound back to you've had 4 to 7% off plateau there. So it's not realistic. People come in and say, okay, I want to lose about 200 pounds by the end of next year. That's not going to happen with diet and exercise alone. And then we look at treatments that we can use and what percent body weight loss can you get in addition to lifestyle. It's like smoking cessation. If you don't want to quit, no medication out there is going to make you quit. If you don't have lifestyle changes that go along, then the medications are going to be less effective. But you can expect a little more. Now, depending on the medication, you can get between an additional 6 to some of the newer ones are going to be up close to 18% of additional body weight loss. But anytime you stop any of this medication or stop whatever lifestyle change, you're going to go back to where you had been. The ultimate losing 25 to 50% of body weight has to be surgical. We do not have any diet or exercise or medication that can yet match bariatric surgery. Now, they're hopeful. We won't get into future medications because they're not going to be out for a little ways yet, but they're hopeful that they will be able to understand the physiology enough to design something that can match bariatric surgery without a scalpel. We're not there today. So short term, 5 to 10% body weight with lifestyle, additional, let's say 5 to 10, 12% if we go with medication, but it's not a fast process and there's a lot of plateauing that you got to stick through. And so having some reasonable expectations that like, oh, going to be, 200 pounds down in 12 months. I think some people come in with that and get frustrated when they're, 10 pounds down in 2 months. We say, hey, that's great. 1 to 2 pounds a week is a great target. And even that's hard to do and maintain for sure. But people, they say, oh my gosh, I'm doing this for a month. And I still haven't gone down 3 sizes in my clothes. So you have to have that kind of expectation. I hope that answers
that totally answers the question.
I think that's a great segue for part 2. We will be back next week with our part 2 episode, and we'll talk a little bit more about just different diets that you've seen, different diets we've talked about before, and kind of the goods and bads of all. But until next week, where can people find you on the internet, Caitlin?
You can find me at Fat Caitlin on TikTok, at the Caitlin Dean on X, Caitlin Dean on Facebook, Kate and Isaiah Living Large on Facebook. What about you, Isaiah?
I am at Maritime Brews on all of the social medias.
And doctors don't want you to find them on the
And
internet.
doctors don't want to. That is correct.
Yeah. Fair enough.
But until next week, bye.
Bye.